Welcome to this module on the innovations aimed at facilitating uninterrupted HIV service access and utilization. The target audience for this training module is both health professionals and communities. The information contained in this module is designed for those providing HIV care, physicians, nurses, pharmacists and community health care workers, and for communities of people living with and affected by HIV. Let's start by reviewing Collateral Systems. The 4 key implementation themes in PEPFAR's 21 Colombian pesos guidance are client-centered services, community engagement, resilient and adaptive approaches and support for sustainable capacity. What do we mean by collateral mortality? We know that natural disaster like earthquakes, hurricanes, tsunamis, tornadoes, and floods bring to mind images of toppled buildings and impassable streets, but in the aftermath of natural disasters also comes the unseen and seldom discussed collateral mortality which accompanies such emergencies: the loss of continuity and care for those living with HIV. That loss has individual consequences but also severe ramifications in the battle against HIV epidemic. Efforts to achieve universal access to HIV prevention care and treatment can only succeed if HIV programming is included in emergency preparedness plans, something that usually does not happen. The COVID-19 pandemic, and outbreaks of other deadly diseases such as Ebola, has taught us just how severely HIV service delivery can be impacted. Key elements of HIV care preparedness plans include contingency planning to ensure continued supply and access to ARVs, access to food assistance if needed for people on antiretroviral therapy, uninterrupted access to condoms, continuation and reinforcement of anti-stigma campaigns, and learning from the past which HIV services were most impacted. In the context of the COVID-19 pandemic, viral load testing and new ART initiations were among the most impacted services. In this study from 65 primary care clinics in KwaZulu-Natal, South Africa, COVID-19 lockdowns were associated with a 47.6% decrease in HIV testing and 46.2% decrease in ART initiations, but no marked change in the number of ART collection visits. ART provision was generally maintained during lockdowns, but HIV testing and ART initiations were heavily impacted. Strategies to improve testing and initiation were implemented. But there is evidence that the impact on HIV treatment services was less severe than feared. Here we see trends in people on ART across 5 African countries. The number on ART for the lockdown months of February through July of 2020 did not change much, if at all, compared to the pre-lockdown month of January. In terms of resource mobilization, the Global Fund and partners quickly established the Access to COVID-19 Tools, or ACT, Accelerator, which is a global collaboration to accelerate access to the development, production and equitable access to new COVID-19 diagnostics, therapeutics and vaccines. There was an initial investment of $1 billion with an ongoing need for another $5 billion to continue to battle COVID-19 by protecting both healthcare workers and systems for health to maintain progress against HIV, TB and malaria. Another example of resource mobilization is the COVAX facility, under which WHO, UNICEF and partners have distributed free COVID-19 vaccines to 114 countries around the world. Returning to PEPFAR's key implementation themes, front and center is differentiated service delivery, supporting client-centered services and community engagement. We all know what we mean by differentiated service delivery, or DSD. It is the client-centered approach to HIV care and treatment which tailors services to different groups of people living with HIV and their specific needs. DSD may include decentralized drug distribution, such as alternative pickup points in communities, through community pharmacies and by community-based organizations, CBOs, home delivery often supported by CBOs, and automated systems such as smart lockers or pharmacy dispensing units, PDU. Differentiated service delivery models tailor HIV treatment by location, provider cadre, frequency of visits, and package of services and can be adapted to subpopulations that have specific needs. These models reduce congestion at treatment facilities and have been shown to improve patient retention and viral load suppression. They also enable program staff to spend less time and resources on clients who are doing well on treatment and allocate more time and resources to clients in need of greater support. Visit spacing, multi-month dispensing, MMD, and decentralized drug distribution are interventions that have been accelerated during the COVID-19 pandemic. Here are 5 ways in which differentiated service delivery, DSD, for HIV treatment has been accelerated during COVID-19 in terms of policy and implementation. These are: expanded eligibility for DSD, reduce the frequency of clinical consultations, extended multi-month dispensing, MMD, emphasized integration of other medications, emphasized community-based models, and decentralized drug distribution. And accelerated DSD should continue after the pandemic. We need to ensure that policies implemented in response to COVID-19 become the new normal. 6-month dispensing is preferred, but there may be circumstances where 3-month dispensing is necessary. At a minimum, most clients at ART treatment sites should be offered prescriptions for 6 months of ART, and a fast-track refill model at the site should be adopted. Differentiated service delivery, DSD, models for HIV often exclude children and adolescents. Alignment of children's clinic visits with their caregivers' appointments, including the location and date of the visit, should be strongly encouraged. Implementing a family-based differentiated service delivery model fosters continuity of treatment for both caregivers and children. Looking at the treatment cascade, we find that men are less likely to be diagnosed with HIV and are diagnosed later. Women are more likely to link to care and initiate ART, while men are less likely to achieve virological suppression. Men are more likely to interrupt treatment and have a higher mortality than women. However, data from PEPFAR suggests that 95% of men return to care with the support of a man living with HIV serving as a coach or linkage facilitator. Here are some examples of DSD for men. Early morning ART refills at clinics in Zambia and Eswatini, which provide recipients of care with the option to receive screening and medication before the morning rush. This model enables greater privacy for men who face discrimination or stigma when accessing services. Workplace HIV testing in Eswatini, which reduces barriers by enabling men to conveniently access services. Another example, and some quotes from a man who has dedicated his time to bringing men into care. I know that men don't like to come to the clinic because they hate spending hours sitting in the queues. But most importantly, they don't feel comfortable with being attended to by a female health worker. Don't worry, my brother. Come with me to my office, and I can help to fast track you so that you don't spend hours here waiting to be seen by the nurse. Let's turn now to another new PEP for 2021 priority, comprehensive case management. Rapid ART initiation, within 7 days of testing positive but ideally on the same day, results in improved outcomes across the HIV treatment cascade, including greater ART adherence and viral suppression. Rapid ART initiation for key populations should be offered at various points of entry, meeting the client where they can best be served, including at community testing sites, drop-in centers, STI clinics, private clinics, primary care clinics, and hospitals. Comprehensive case management teams should support rapid ART initiation for newly diagnosed key populations members and gay people who have been lost to follow-up. Comprehensive case management teams can be composed of HIV counselors, peer navigators, mental health providers, clinicians, and monitoring and evaluation, M&E, staff, many of whom ideally are gay people themselves. In settings where KP members are newly diagnosed with HIV in a community setting, an integrated case management approach can facilitate linkage from the community to public health systems for rapid ART initiation and continuity of care, or to a KP community clinic. Differentiated key populations case management is important to ensure a people-centered approach. Some clients require a more intensive package of services than others. These can also be progressive, where an unstable client enters the program with intensive needs, stabilizes and later, after ensuring viral suppression, needs less care. Frequent, personalized support and counseling from the time the client enters the program until sustained viral suppression is achieved. Integrated data sharing between facility and community partners is fundamental to scaling up a case management approach. Regular communication with the client and check-ins with their peer navigator or healthcare team can help identify missed appointments. Their check-ins could be online and less frequently in person, with the need for event-driven reminders such as a reminder for VL testing. For ART clients facing barriers to regular clinical care and ART adherence, i.e., homelessness, substance use, complaints of mistreatment at clinics, and for those who have fallen out of care previously, continuation of case management is recommended. In Namibia, many key populations will be supported across 73 sites using peer navigation assisted by an online case management system. Zimbabwe defining models of services for key populations living with HIV based on intensive or maintenance models to support the sustainability of KP programs nationally. What about the cost? A study of a case management system in 3 provinces in Mozambique reported that the case management cost per beneficiary between enrollment and graduation averaged US $4.67, client. Finally, we will look briefly at continuity of treatment return to treatment, the new terminology from PEPFAR. PEPFAR's 5 core elements for advancing continuity of ART are: commitment by stakeholders to client-centered approaches, implementation of minimum program requirements related to linkage and continuity of treatment at all sites, implementation of evidence-based site-level minimum standards for continuous ART as part of a client-centered service environment, specific, customized interventions to improve continuity and return to treatment after interruption, designed around specifically addressing challenges noted by current clients and clients' return to care, opportunities, and assets specific to the OU and its FY 2021 COP/OP guidance for all PEPFAR countries, page 52 of 665 communities. Simply finding and returning clients to the same site if issues persist will result in losing the client again. Site-specific issues must be addressed, and all technical assistance partners' performance evaluations must include specific goals for continuous treatment. Implementation of quality management policies and practices to support and maintain site standards. PayPal makes the point that simply finding and returning clients to the same site if issues persist will result in losing the client again, and that site-specific issues must be addressed. 21 Colombian pesos also includes a recommendation that site performance evaluations must include specific goals for continuous treatment. Return to treatment, RTT, of clients whose treatment has been interrupted is a high priority for all treatment sites and requires coordinated facility and community efforts. Consistent, affirmative welcome back messaging that avoids negative consequences of interruption of care and provides positive reinforcement for re-engagement is also a priority for PEPFAR. Continuity of care after treatment interruption should be tailored to individual clients. Re-engagement service delivery algorithms should be developed which clearly set out an expedited timeline to access MMD and DSD models. For example, if the issue is distance to the clinic, a client should be supported with 6-month appointments and 6 months of medication with routine phone follow-up. Access to multi-month dispensing of medications should not require clients to prove they are taking their meds. Please take a moment to review this for tracking and tracing clients who missed scheduled appointments. Please take a moment to reflect on these questions related to what you have just seen in the presentation. Had you heard of collateral mortality in the context of health before, and what do you think of the concept? Do you think it's helpful for your work? Did you learn anything new from this section on differentiated service delivery? If yes, what was new for you? Was the section on comprehensive case management useful in our day-to-day clinical practice, and how so? What are your thoughts on the section on continuity of treatment and return to treatment?